Welcome to Pathology Central Key Concepts. The topic of this video is central nervous system neoplasms and familial tumor syndromes. There's a lot of material to cover in this video, and the World Health Organization has just updated their classification system for CNS tumors. So there's going to be some new and very interesting material in this video. I'm going to begin by comparing and contrasting the different types of adult-type diffuse gliomas. Next, I will describe the clinical pathologic features of pediatric tumors of the central nervous system, and I'll finish up by reviewing the pathophysiology and morphologic findings of the familial CNS tumor syndromes. So first, though, let's think about CNS tumors in general. So unlike carcinomas, there is no morphologically evident premalignant or in situ lesion. Another important fact about CNS tumors is that even low-grade lesions may cause significant clinical deficits due to wide infiltration. And because of this infiltration, it may not be possible to get a clear and total resection, and therefore even low-grade lesions can have a very poor prognosis. Location of the tumor is critical for central nervous system tumors, not only for prognosis, but also for causing symptoms. So for example, tumors that obstruct the flow of the cerebrospinal fluid will result in pressure hydrocephalus. If they arise in the brainstem, we can get cardiopulmonary arrest, and lesions can also present as seizures. One thing that we know about central nervous system tumors is that typically tumors in adults will be supratentorial, so in the cerebral hemispheres, whereas tumors in the pediatric population tend to be infratentorial, so in the cerebellum. Symptoms for CNS tumors may be global, for example, due to increased intracranial pressure leading to nausea, headache, and vomiting. Or they can be focal, so you can get motor, language, and word-finding deficits similar to what you would see in a stroke. And even high-grade tumors rarely metastasize outside the central nervous system. And finally, molecular analysis is increasingly important in diagnosis and prognosis. It used to be that neuropathologists would look at slides and based on what they saw would make their diagnosis. And generations of medical students have learned these criteria and tried to identify, for example, the classic fried egg appearance of oligodendrogliomas. But the truth of the matter is that we are using molecular analysis for our diagnosis because there can be a lot of overlap in appearance. So this means that some of the things you may be asked to memorize for things like your step exams aren't really applicable to what we see in neuropathology practice. However, the board exams do tend to lag behind the progress in the scientific community, so you will probably have to go ahead and learn those appearances. Now, there are a wide range of tumors of the central nervous system. I'm not going to cover all of them in this video, but I want to point out a few things. So gliomas are tumors of brain parenchyma, and we classify them now with the new WHO classification as adult-type diffuse, of which there are 3 variants that I'll be discussing. The pediatric type diffuse, which I won't be covering, it's not particularly common, and it has a particular molecular findings. And then pilocytic astrocytoma, which is a glioma, but unlike these is not diffuse. It tends to be well circumscribed. Some other tumors include ependymoma, which I'll be discussing, as well as medulloblastoma, but there are a variety of other less common tumors you can see in the central nervous system, and of course you always have to consider metastatic disease. So one way of classifying central nervous system tumors is by the population that is affected. And that's the approach I'm taking in this video because in your practice, you will probably either be treating adults or children. So you'll have different considerations based on that population. So in adults, we tend to think about our adult-type diffuse gliomas, astrocytoma IDH mutant, glioblastoma IDH wild type, and oligodendroglioma, which is IDH mutant and 1p19q co-deleted. In children, we'll be focusing on pilocytic astrocytoma, ependymoma, and medulloblastoma. So let's begin with the adult-type diffuse gliomas. So the first one we'll look at is astrocytoma IDH mutant. It tends to present in the 4th to 6th decades of life with seizures, headaches, and focal neurologic deficits. We grade these according to the World Health Organization as grades 2 to 4. We don't use grade 1 because grade 1 implies that it's benign, and these are not benign. The pathogenesis will be driver mutations of the isocitrate dehydrogenase 1 gene, or IDH1. Less commonly, we can see driver mutations in IDH2. Now, you may be thinking, where have I seen isocitrate dehydrogenase 1 before? That took place in the neoplasia chapter of Robbins, and I'm going to review that for you now. So as you'll recall, in your citric acid cycle, isocitrate dehydrogenase plays a role here in this pathway. But when we have this particular mutation, we're going to generate an oncometabolite called 2-hydroxyglutarate, or 2-HG. Now, typically, what 2-HG will do is it will inhibit TET family enzymes. And the role of the TET family enzymes, such as TET2, is to regulate DNA methylation. So if you block this using 2-HG, you're going to lose TET2, which is going to lead to increased DNA methylation and altered gene expression, which can lead to cellular transformation. So what do we see when we look at an IDH mutant astrocytoma? So grossly, the lesions, all of the lesions will be poorly defined infiltrative tumors that are going to expand and distort the tissue without forming a discrete mass. Now, I highlight here that grade 4 has a particular lack of finding, and this distinguishes it from what we will see in the IDH wild-type glioblastomas, which is the next tumor we'll look at. These tumors, even though they're high grade, lack large areas of central necrosis and hemorrhage that are characteristic of this lesion. Now, microscopically, we have different findings depending on grade. And basically, as you increase in grade, you will be increasing in cellularity as well as nuclear pleomorphism and mitotic activity. Once we get to grade 4, we may see microvascular proliferation and necrosis. And I'm going to show you a picture of this when we talk about the IDH wild-type glioblastomas, because that's much more characteristic for that lesion. But first, let's go ahead and take a look at the gross of this IDH mutant astrocytoma. You can see here we have the healthy hemisphere here, and this is the area that is expanded by this infiltrative astrocytoma. You can see here that the gyri are very expanded. You can also appreciate that we don't have, for example, a small tumor mass. It's hard to recognize where exactly this tumor ends. In order to resect it would be a significant portion of the brain. And even with that, there would probably be small tentacles of tumor that were not able to be resected. This is a grade 2, so it's got increased cellularity, and the lesional cells are actually these hyperchromatic, somewhat angulated nuclei here, which you can appreciate. One way that we can recognize this tumor, it is IDH mutant. We can do a stain for IDH1, which helps us to recognize and make this diagnosis. The clinical features for this particular tumor is that the tumor may be static for several years, but they will eventually progress and develop high-grade histologic features with increased tumor growth and rapid clinical progression. Typically for patients who have a grade 2 tumor, survival is more than 10 years, but as it progresses, survival will decrease. And when a patient has a grade 4 lesion, survival is typically about 3 years. Now this brings us to glioblastoma, IDH wild type, which you may see in some older books is a reference to glioblastoma multiforme, as well as some discussion of glioblastoma with IDH mutations and without IDH mutations. That has changed with the new World Health Organization. If it is called a glioblastoma, it is by definition IDH wild type. It is the most common malignant glioma. About 50% of gliomas in adults are glioblastomas. It has a very high grade and a very poor prognosis. Now, unlike the IDH mutant tumors, there are multiple pathways and multiple genetic alterations. And these tend to affect our hallmarks of cancer. And I would encourage you to go back to the hallmarks of cancer video for a refresher. Here are some of those hallmarks that are being evaded. So we have evasion of senescence, escape from normal growth control, activation of growth factor signaling pathways, and resistance to apoptosis. So for example, to evade senescence, we can get mutations in telomerase or mutations that lead to alternative lengthening of telomeres. To escape normal growth control, we can lose our cyclin-dependent kinase inhibitor P16. Remember that our cyclin-dependent kinase inhibitors are going to inhibit our cyclins and cyclin-dependent kinases and slow progression through the cell cycle. Another way to move towards neoplasia is to activate growth factor signaling pathways. A key way of doing this is through amplification of receptors, and this can be done through gene amplification of epidermal growth factor receptor and platelet-derived growth factor receptor. And finally, we can get resistance to apoptosis with TP53 mutations. So morphologically, I'm going to go over the radiology, gross, and microscopic. So radiologically, what we will see is the characteristic ring-enhancing lesion. Now we see this, and it is when you give contrast, IV contrast to a patient, we're going to see enhancement at the periphery of the tumor due to the leaky tumor neovasculature, which is something I also covered in the Hallmarks of Cancer videos. This leads to a permeable blood-brain barrier and will have that ring around the tumor, and I'll show you an image in a moment. The gross appearance of a glioblastoma is heterogeneous. There will be areas that are firm and white, other areas that are soft and yellow due to necrosis. We can see cystic degeneration and hemorrhage. So grossly, this is going to be very apparent that it is a glioblastoma, in contrast to the grade 4 astrocytoma I described earlier. Microscopically, it's going to look very similar to our grade 4 astrocytoma with high cellularity, poor differentiation, increased nuclear atypia, and brisk mitotic activity. But it is also characterized by these two features: significant necrosis, which tends to have a serpiginous appearance with tumor cells that are lined up in parallel or palisaded around the border, and a microvascular proliferation. Now, as I mentioned, you can also see that in astrocytoma. What we can do, however, is to use molecular techniques to make the diagnosis. So here we see the radiology. This is the tumor, and you can see there's this ring here, and this is the contrast that has accumulated through those new tumor leaky vessels. And here is the appearance of the tumor. As I mentioned, very heterogeneous. You can see areas of hemorrhage here. Here's a cystic area here, more cystic area here with some necrosis. And then microscopically, this is that serpiginous appearance of the necrosis with the cells lined up in parallel along them. This is referred to as palisading. And these are the microvascular proliferation. Often when students think microvascular proliferation, they think of something like a branching capillary network. Instead, what we see are these almost glomeruloid structures, these little balls of vessels. So that's what we mean when we talk about this microvascular proliferation. And then just to give you another view of one of these tumors to compare it to that grade 2 astrocytoma I showed you earlier, so you can appreciate the increased cellularity. You can see there's areas of hemorrhage here, and here is a mitotic figure. So this is a very aggressive tumor. Typically it will present in the 6 to 8 decades in the cerebral hemispheres, although it can also arise in the basal ganglia and thalamus. Patients will present with seizures, neurocognitive impairment, nausea, vomiting, and possibly severe pulsating headache. This is a very aggressive tumor, and even with optimal therapy, with surgical resection, chemotherapy, and radiation, survival is typically less than 18 months. This brings us to our last of the diffuse type, adult type gliomas, oligodendroglioma, which is defined as IDH mutant and 1p19q co-deleted. So I have to let you know that we didn't used to use this additional label. They were just called oligodendrogliomas. But what we found is that while there were tumors that really looked like they were composed of oligodendrocytes, so round, smooth nuclei, what we found is there were a lot of tumors that didn't look like oligodendrocytes that were showing these characteristic molecular findings. So the molecular findings are now part of the diagnosis. The WHO grade will be 2 or 3, and these tumors have the best prognosis of the diffuse glial tumors. They tend to arise in the 4th to 5th decades in the frontal and temporal lobes. And their presentation they're somewhat indolent tumors, so there may be several years of antecedent neurologic problems such as seizures before a patient finally gets imaging and is recognized to have a tumor. With appropriate therapy, surgery, chemotherapy, and radiation therapy, grade 2 tumors have a survival of 10 to 20 years compared to about 5 to 10 years for grade 3. Now we know that these tumors have this 1p19q co-deletion. We don't know what the role of that is at the pathogenesis. We also have our oncometabolite 2HG being formed by our IDH mutant. And these tumors will also often have mutations in the TERT promoter, which will lead to increased telomerase activity. So what do we see grossly? These are gelatinous gray masses that may have cyst formation, areas of focal hemorrhage, and calcification. Now this calcification may be apparent grossly or through radiologic imaging. I'll show you a picture of that in a moment. Or it may be microscopic calcification. So the classic appearance of oligodendroglioma that generations of medical school students have learned is sheets of regular cells with spherical nuclei surrounded by a clear halo, the fried egg appearance. So just wanted to let you know that while you will probably still have to memorize that for your board exams, it is much more nuanced and subtle than that in neuropathology practice. There will be a delicate branching or chicken wire vasculature, and about 90% of cases have calcification. Mitotic activity is low, though it will be increased in our grade 3 tumors, which will also have increased cellularity, increased nuclear anaplasia, and may or may not have some microvascular proliferation and necrosis. So here again is that classic appearance. You can see it looks very much like little fried eggs. We have our branching capillaries through here, but we've also done our immunohistochemical stain for IDH1, which is going to confirm this aspect of the diagnosis. We also have to prove that we have a 1p19q co-deletion. Now, as far as those calcifications go, here you can see on the CT image a large, chunky mass of calcification, or it can be more subtle, as in these microcalcifications. Again, this tumor is nicely showing that fried egg appearance. So that is the last of the adult diffuse type gliomas. Now let's move into our pediatric neoplasms. I'm going to begin with pilocytic astrocytoma because it too is a glioma, but in contrast to those other lesions, it is circumscribed and tends to affect children. So it's a relatively benign tumor of children and young adults. Most commonly will arise in the cerebellum, though also can originate in the third ventricle, optic pathways, and spinal cord. Symptoms will be related to the mass effect. It can cause obstructive hydrocephalus, and because of that obstructive hydrocephalus, increased intracranial pressure. And it's usually curable with complete resection. Now, the pathogenesis of this is activation of the serine threonine kinase BRAF, which activates the MAP kinase signaling pathway. And I'll show you that in a moment. And these do not have IDH mutations. So we've already covered BRAF and its role here in cell growth and cell signaling. But I'm just going to do a quick review for you. This is covered in the neoplasia chapter. Remember, we have our quiescent cell with a growth factor receptor. The growth factor binds, stimulates the growth factor receptor. Through an adapter protein, we're going to get activation of RAS with transformation of GDP to GTP, so we have activated RAS. That's then going to start these signaling cascades like the PI3K pathway and the RAF pathway, leading to MAP kinase, increased transcription of pro-growth genes, onward through here to cell growth. I encourage you to watch the Hallmarks video if this does not seem familiar. Morphologically, we're going to see grossly a circumscribed lesion, which is usually cystic with a mural nodule of tumor. And the reason we call it pilocytic is because microscopically we see these long, thin, hair-like processes. Pilo means hair. Another finding is Rosenthal fibers, which are eosinophilic granular bodies, and I'll show you an image of that as well. And uncommonly, we can see necrosis in mitotic figures. So here you can see a pilocytic astrocytoma in the cerebellum. This is the mural nodule of tumor, and this is the cyst with this sort of gelatinous contents in it. Histologically, you can, I think, easily appreciate these thin hair-like processes and see why we call these pilocytic. And then here is the Rosenthal fibers, these globular masses or somewhat fibrous appearance of these just densely eosinophilic to magenta proteins. All right, this brings us next to ependymoma. So ependymomas can arise in any age group, but are most common in children and young adults. So they arise next to the ependymoma-lined ventricular system, including the central canal of the spinal cord. However, in the first 2 decades of life, they typically arise near the fourth ventricle and classically will lead to hydrocephalus. In adults, however, you can see them in the spinal cord, particularly in patients who have neurofibromatosis too. Now, with the new WHO classification, it's gotten quite complicated. There's a combination of histopathological features, anatomic sites, such as whether it's supratentorial or posterior fossa, as well as molecular alterations, such as a couple of different fusion proteins. Just suffice to say that this is a very complicated classification system. Pathogenesis is related to NF2 mutations in our spinal ependymomas, as well as other driver mutations in other ependymomas. And the prognosis is excellent. Completely resected supratentorial and spinal tumors tend to do better than the posterior fossa tumors. So what do we see morphologically? Grossly, it's going to be a solid or papillary mass with cystic degeneration. And then, as I mentioned before, as we saw with astrocytic tumors, we had with the pilocytic astrocytoma, we had those fine hair-like processes. We're still going to see some fibrillary processes in the ependymoma. The nuclei are round to oval and they have a granular cytoplasm. But what we'll be looking for in ependymomas are these two. We're going to be looking for rosettes and pseudo-rosettes. So in rosettes, we have gland-like round or elongated structures that resemble the embryologic ependymal canal, and they have these long, delicate processes extending into the lumen. We can also get these perivascular pseudo-rosettes in which cells are arranged around vessels with intervening zone of fibrillar processes. So let's begin first by looking at our gross. This is a lesion arising from the fourth ventricle. You can see the tumor mass here. And here's another larger tumor, again arising from the fourth ventricle here in the cerebellum. Now this is showing our true rosettes. We call them true rosettes because they have this lumen in the center, and you can see that they really do appear like glands or like that embryologic structure, and there are little fibrous processes or that are fibrillar processes extending towards the lumen. Now these here are pseudo-rosettes, but they're not optimal, so let me show you a better picture. Here is one where you can see these palisaded nuclei. Here's that central vessel, and here are these fibrillar processes reaching towards that vessel. So these are pseudo-rosettes. This brings us to the last tumor that I'm going to talk about before we go into the familial tumor syndromes. This is medulloblastoma. So this is considered to be an embryonal neoplasm because the cells appear primitive and undifferentiated. It accounts for about 20% of pediatric brain tumors and arises in the cerebellum, from which it may seed the spinal fluid. This is referred to as drop metastases. It's a highly malignant, vigorously growing tumor, but it's very sensitive to radiation. So with appropriate therapy, so total excision, radiation, and chemotherapy, 5-year survival is about 75%. Now there are a number of pathogenetic pathways. One of them is through the sonic hedgehog pathway. Sonic hedgehog controls proliferation of our cerebellar granule cells. And patch 1 is a protein that's a negative regulator of sonic hedgehog. And when we get a germline mutation in patch 1, these individuals tend to get medulloblastomas as well as basal cell carcinoma. Basal cell carcinomas can also have patch 1 mutations. TP53 mutation can also be seen in medulloblastoma. And then the third pathway is activation of Wnt and beta-catenin signaling pathway. And of these three pathways, sonic hedgehog and T53 are associated with a worse prognosis. The Wnt signaling pathway has a better prognosis. Now, morphologically, on radiology, we're typically going to see hydrocephalus due to this midline mass in the cerebellum of children. In adults, it tends to be a little bit more lateral. And as I mentioned, we can see drop metastases, and I'll show you an image of that. Grossly, these are well-circumscribed friable masses, and what we'll see histologically are these dense sheets of small primitive-appearing cells with scant cytoplasm and hyperchromatic nuclei with abundant mitotic figures. And then a finding that we can see here is something called a Homer-Wright rosette, which is a ring of primitive cells around central neutrophil. So let's take a look here. This is the classic appearance of a medulloblastoma. Here we have the tumor arising here in the cerebellum. It's blocking CSF flow, causing this pressure hydrocephalus, leading perhaps for this patient to nausea, vomiting, and headaches. And then here's some imaging showing drop metastases from a medulloblastoma, where seeds of these little cells have dropped into the cerebrospinal fluid and colonized here. Here is a gross image where you can see, again, here's this the cerebellum. Here's this tumor in the fourth ventricle, has a somewhat variegated appearance, a little bit friable here. And then one more example arising from the vermis of the cerebellum in this patient here, again, well circumscribed. This is the best picture I was able to find of Homer Wright rosettes. You can see them here and here. So we have our three different findings. So we have our full-on rosettes that we see in our ependymomas, our true rosettes that have a lumen. We have our pseudo-rosettes that have a blood vessel in the center, and then we have our Homer Wright rosettes where you have just this pink blob in the middle. That's the neuropil, these processes extending into towards the center. And then here we have the typical appearance of these cells, very monomorphic and uniform with minimal cytoplasm. They really just look like almost naked nuclei. All right, that's the last of the individual tumors I'll be addressing. Let's move on to the familial tumor syndromes. And the first of those will be neurofibromatosis type 2. One of the reasons I want to talk about it is that's going to give me a chance to sneak in this additional tumor, the meningioma. So neurofibromatosis type 2 has a variety of findings, but it is characterized by bilateral vestibular schwannomas, which are neoplasms of the 8th cranial nerve. We also can get multiple meningiomas and ependymoma of the cervical spinal cord, which I've already referenced. Now, meningiomas are benign dural-based tumors that arise from meningothelial cells of the arachnoid. The gene NF2 encodes a protein called Merlin, so we will find these multiple meningiomas that have loss of function of Merlin. We also can see a mutation in NF2 in about 50 to 60% of sporadic meningiomas. Histologically, we'll see whorls of cells with indistinct cell boundaries. That's referred to as a syncytial appearance. And they will frequently have psammoma bodies, and I'll show you a nice image of those. Let's begin with a gross image. Here's an image from pathologic basis of disease where you can see this very well circumscribed mass arising from the dura. Here's another one from Robbins and Kumar basic pathology where you can see here we have indentation of the underlying brain. Now, uncommonly, we can actually get invasion into the brain by meningiomas, but for the most part, they are well circumscribed and simply cause compression. Now, what we will see histologically is these whorls of cells, so they have this almost swirling appearance, and it's difficult to make out the cell boundaries. The nuclei are quite regular. And then here are the classic psammoma bodies associated with meningiomas. Psammoma means sand, and they have this lamellar appearance, almost onion skin, whirling appearance here to these psammoma bodies. Now, the next syndrome that has central nervous system component that I'd like to address is tuberous sclerosis complex. So this is an autosomal dominant disease that occurs about 1 in 6,000 births, and it's characterized by hamartomas and benign neoplasms of brain and other tissues. And as you can see, there are a lot, so I'll talk about those in a moment. The CNS findings tend to result in seizures, autism, and intellectual disability. There are also some classic skin findings such as ash leaf patches and shagreen patches, which may bring a patient to attention. Now, in the central nervous system, we see three things in particular. One is called cortical tubers, from which the name tuberous sclerosis. They're called tubers because this is an expansion of the gyrus that makes it look a little bit like a potato. We can also see subependymal nodules and a particular type of astrocytoma called a subependymal giant cell astrocytoma, or SEGA. The extra CNS findings are manifold. So renal angiomyolipoma is covered in the renal tumors video. I also will draw your attention to cardiac rhabdomyomas, which is discussed in Robbins, and then these skin findings as well. So let's take a look at what we see as far as the pathogenesis goes. There are two genes that can be involved in tuberous sclerosis, TSC1, which encodes Hamertin, and TSC2, which encodes tuberin. And of these two genes, tuberin is the one that is more commonly mutated in tuberous sclerosis. Now, these two proteins, Hamertin and tuberin, form a complex that will inhibit mTOR kinase. And mTOR is a key regulator of protein synthesis as well as other anabolic functions. And when you get unregulated mTOR activity, you can get cells that are really quite large. And that accounts for this giant cell component of our subependymal giant cell astrocytoma. So this is a cartoon from Expert Path that I think sort of brings things together nicely. These light yellow areas with the white arrows are these cortical tubers, where you have expansion of the gyrus. This black arrow here is showing a subependymal nodule, and then here is a sega. So let's take a look at an actual gross specimen. Here you can see a subependymal nodule. It's got a little bit of calcification to it. And then this is the cortical tuber, so you can see this sort of expansion and widening of the gyrus. And then just one last image of tuberous sclerosis. This is, in fact, a subependymal giant cell astrocytoma. Look at those giant cells. This is due to dysregulation of mTOR. All right, our final disease we're going to discuss is von Hippel-Lindau disease. This is an autosomal dominant disease. It's quite rare, 1 in 30,000 to 40,000 births, characterized by hemangioblastomas of the central nervous system, as well as there can be hundreds of cysts in the kidneys, liver, and pancreas. We can get renal cell carcinomas as well as pheochromocytomas. The pathogenesis here is that we get loss of function of the VHL tumor suppressor gene. Now, VHL is part of a ubiquitin ligase complex that downregulates a transcription factor called hypoxia-induced factor 1, or HIF1. And HIF1 regulates a number of genes, including the expression of vascular endothelial growth factor, erythropoietin, and other growth factors that will lead to increased vessel growth. It also regulates expression of genes that control cellular metabolism and cell growth. So let's take a look at what we would see morphologically. So hemangioblastomas are highly vascular neoplasms, as you would imagine, based on the increased VEGF. They tend to appear as a mural nodule in a fluid-filled cyst, which we can see here in the cerebellum. And then the cells that are the blastoma part, so blast we think of as being sort of like a primitive cell, hemangio obviously relating to the vascular component. These are vacuolized lipid-filled cells that express VEGF and erythropoietin. So patients with these may have polycythemia, so increased red cell mass due to erythropoietin expression. And here is an example of the tumor, and you can see why we get hemangio in this. Look at all of these blood vessels, all of these red cells percolating through, and then you can see these vacuolized lipid-laden cells here. So as always, here are some questions. I'd recommend you go ahead and pause the video and see if you can answer these questions. If not, maybe watch it again. As always, please follow me on Twitter. I really appreciate comments down below, so thank you for that. And also thank you for your time and attention.